Come on, we coming.
Test 1 2 1 2 1 2 1 2 3 1 2 3.
She talked to somebody that was doing all this, and she asked them about East, and they didn't. She said that East would be able to do it, or whoever it was, and then she never came over again. And we never
Good afternoon. My name is Todd Jenkins, and I am an obstetrician gynecologist currently at the University of Alabama at Birmingham, and it's my honor to come and talk to you guys about cervical cancer screening, an area that has changed a lot over the last several years, and I want to spend most of the time trying to explain why that change has occurred, because it really changes how you think about what we do as far as screening. So our goals for the next few minutes are to describe the causes, natural history, and really try to get a good understanding of human papillomavirus, or HPV, as we use it in cervical cancer screening. Number two, to discuss the rationale for why we've changed how we do things so much in gynecology. And then we'll go through a few examples of how this is applied. I have no disclosures that should conflict with this presentation. So I know most people, their attention fades after the first few minutes, so I thought I'd give you the take-home first 5 things to take away right up front so you could just drift on. And number one is, if we really want to affect cervical cancer, we've got to reach the people that aren't being seen. The large majority of cervical cancer cases in the United States, especially and across the world, are in people who've either never had any screening or were screened inadequately. So if we really want to, while we're going to spend the rest of this talk talking about how we screen the people that show up, if we really want to make a big difference, we need to do a better job of getting people to be screened. Number two, you can stop all the arguments. There really isn't that big of a difference as far as cervical cancer screening between the newer liquid-based as well as the old, I'm dating myself, the old Final Net, when we used to do a pap smear and spray hairspray on it to fix it. The liquid-based do give us a lot of other options in the sense that we can screen for certain sexually transmitted infections using it. We can run human papillomavirus, but as far as just pap smear to pap smear, it's not that different. This is probably the biggest point we're going to make throughout the rest of this talk, is we now look at cervical cancer from an infectious disease standpoint rather than a cancer standpoint, because we know that infection with the high-risk HPV types is what leads to squamous cell cancer of the cervix. Now, this is the phrasing on this slide that most documents use, is necessary but not sufficient, meaning if you don't have HPV, it is extremely, almost impossible to develop any type of cervical cancer. However, the large majority of women who get HPV will be fine. So it's something else. And that's what we don't know yet. And again, this is what I alluded to earlier. We're really looking at changing the way we look at it from a screening to an infectious disease standpoint. And can we cure it with a vaccine, or you all should be aware of the vaccine Gardasil that's available for pre-exposure, but there's actually now a vaccine for women who are already infected that's actually showing some impressive results. So we may be able to treat this in a different way. And then finally, the algorithms, the management of what you do with a pap smear is just too complicated for words anymore. And so the best $9.99 anyone who does women's health care can spend is buying the American Society for Cervical and Cytologic Pathologies app. You plug in their pap smear, it tells you what to do. I do this all day for a living, and it's what I use. Just because it is, for most things, we don't have a lot of science to base decisions on. But for cervical cancer screening, we have hundreds of thousands of women who've been screened, so there's a ton of data. And if you really do what's best for those women, it gets really complicated, and so the app is great. But let's spend some time talking about the human papillomavirus. I have a friend who always joked with me when we started practicing, cervical cancer was, you have a precancer, we need to treat it, and that's all we did. Now we have to tell the woman, hey, you've been exposed to an STI, and it's a much, much different conversation. But all of this has occurred really over the past 35 years. I always laugh that this slide looks like something that would hang on my grandmother's porch in the flower pots out there. But anyway. So let's talk about HPV. The human papilloma virus is almost exclusively acquired from sex. Yes, there is some vertical transmission at birth. There are some rare, but we pretty much tell patients that it is a sexually transmitted disease. If you have had intercourse with a partner, that partner has about a 40 to 60% chance of being exposed to the virus that you have. And since this is a virus, it is the ultimate in, if you have intercourse with someone, you're having intercourse with everyone they've had before, because viruses have such a long half-life. We always talk to our patients, with other sexually transmitted infections, I can tell you that someone in the last 60 days has brought this into your relationship. For the viruses, it could be their first partner 30 years ago or their last partner. So we don't treat it into who gave this to whom, because pretty much everyone has been exposed. It's everywhere there's a mucous membrane, it is there. And even though babies are exposed at birth, the large majority of them will clear the virus before the end of the first year of life. So this is just kind of some numbers for you. The bar on the left is just if we went out and did a spot check of the prevalence of HPV in the population, you can see that in women it's about 40% of women would be antibody positive, and about 60% of men. But unfortunately for women, the percentage of women that are exposed to a high-risk type is much greater, which is something that we're still struggling to understand. And if you look at it by an age factor, you can see that it really parallels entrance into sexual activity and sexual frequency, with most people being exposed during their 20s. And I want you to keep this slide in mind when we start talking about why it's sort of counterintuitive, why we don't screen with HPV in women in their 20s. So just remember this bar. And you can see about an equal risk of high risk and low risk. Now, most studies have said by the time a woman is 50, she has about an 80% risk of being exposed to HPV at some point in her life. So again, going back to that theme, it's not the fact that you were exposed to it, it's that you haven't been able to clear it that makes us worry. So I sort of alluded to this. The majority of HPV infections are cleared, and in fact the number approaches 90% in some studies. Younger women are much better, they have a better immune system, so they're much better at clearing it than older women. Unfortunately, the low risk types clear it much easier, and unfortunately for women, men have a higher rate of clearance, which is why you see a lower rate of male HPV-related cancers. But here's the information on that. So for a woman, if she's exposed to HPV, anywhere from 40 to 70% will be negative a year later. If you spread that out to 2 to 5 years, you can see the number goes up higher. The range is about 70 to 100%. I usually quote my patients about 85–90% of women by the time they're 2 to 3 years out will be cleared. And you can see that rate is much faster. But again, to emphasize this, the bottom bullet here is among women who aren't in that group that clear the virus over this time, 8 to 25%, depending on the study, will develop a pre-malignant lesion. For those of you that don't do gynecology, CIN stands for cervical intraepithelial neoplasia, which is a pre-cancerous state. CIN2 is what we used to call moderate dysplasia. CIN3 is severe dysplasia. And you can see a small group develop cervical cancer. And the colors are a little hard to see, but this is probably the most important slide in the whole presentation, is if you can see, the white areas are women who were exposed and cleared the virus. And so you can see well over the majority have cleared the virus by 12 months. And this is where I got, if you go out to 24 months, you're talking about 75–80% of women have developed antibodies, cleared this virus, and it's not an issue for them. But then as you see, the longer a woman stays positive for HPV, the more chance she's going to progress, which is that dark color at the very top. And again, it's not that you got it, it's whether or not you can clear it. So this is probably more than you wanted to know, but these are all the ways that HPV testing is already used. Certainly we use it for women over 21 who have an abnormal pap smear. We use it in what's called co-testing in women who are over the age of 30, and then we use it to follow up multiple things. I don't think anybody needs to learn or remember this. Get the app. It's all there, and it just tells you what to do. But you may be asking, and I have a lot of ladies that ask me this in the office every day, is, well, what was wrong with just the plain old pap smear? This is data from England, but and I apologize, the hyphen is missing. This is 1971 to 1995, where they introduced pap smear screening in 1987, and it was covered, and you can see what happened to the rate of cervical cancer. Similar graphs exist here in the US. So the pap smear was working well. Why did we need to go and do more? Well, the problem is the pap smear is very subjective. Our cytotechnologists do a fabulous job, but even they, most of the time, will tell you what they do is a little bit of an art. They're looking, I call it, they're reading tea leaves to sort of figure out what's going on. And so I'm going to show you some evidence that the reproducibility rate of what they give you varies by the lab it's sent to. But the bigger thing is, once you have a lesion on the cervix to see, we're already down the road. It's already there. It doesn't pick it up at a pre-lesion. And so here's that evidence for how subjective it is. This was a large study where they sent their results to 4 different labs. And you can see that if you look at the bottom line, ASCUS stands for atypical squamous cells of undetermined significance, which is why it's ASCUS. It's too big of a name. But even among these 4 labs, the rate of this should be about the same. But in Lab D, almost 10% of women came back with an abnormal pap smear, whereas in Lab A, only 3.8%. And so I usually ask women, which lab do you want to have yours sent to? Because it's actually not totally clear. And when you looked at how many of them found something wrong on a pap smear, this is the frightening part. So the yellow box, all of these women had a moderate to severe dysplasia. And as you can see in Lab A, only 42% were caught by the pap smear. Only 50% in Lab B, all the way up to Lab D that caught 73%. So part of you says, well, I want my cytology sent to Lab D because they're not missing anything. Well, but you're going to see that when you don't miss anything, you overcatch too. So it's a challenge. Now this is looking at it in a different way. This is just a group of studies, all with the endpoint, again, of sort of moderate to severe precancerous disease. And you can see that the rate of just the pap smear picking up disease is anywhere from 40 to 70%, so not that great. So now you may be going back and saying, well, wait a minute, why did we use it? Why do we do it? Well, when you stack pap smears back together year after year after year, you get a really great rate of cancer reduction. So the value of the pap was having it annually. So let's look at what happens when you just do HPV screening. Well, you can see most of the early studies were incredible. The Athena study, the very bottom one, is the largest, and it was like one of those, wait a minute, it may not be quite as good as we thought it was, but it's still better than the pap smear alone. And so then somebody said, well, why don't we put the 2 of them together in what we call co-testing, where we do a pap smear and an HPV. And you can see the sensitivity, the picking up disease to make sure you didn't miss it, got much better. And what about the variability? Well, and if you look at it again at the bottom line, this is going back to those same tests of the 4 labs, it got pretty much the same, 90 to 89%. And that's because it's a DNA marker test. It's not someone looking at a slide and making an interpretation. It's a yes or no answer. So that's why we've sort of begun to move away from pap smears a little bit. The other area is there's another type of cancer of the cervix called adenocarcinoma of the cervix, which actually is more from the cells within the length of the cervix. I always tell ladies that the uterus is sort of like a light bulb, with the cervix being the metal part that screws into the socket. And so within that canal is where adenocarcinoma comes. And as you can see, HPV 16 and 18 are the worst actors in HPV, and they are almost always present when adenocarcinoma is around. So the advantages of screening with co-testing, I've sort of alluded to them. It's more sensitive to pick up pre-malignant lesions than just doing a pap smear alone. But probably both the best and the worst is it allows us to extend the interval that we screen women. So when we were just doing pap smears, for it to be effective, we needed to see you every year. With the two together, we can spread out. There's argument about 3 versus 5 years, but most guidelines now say we can spread out for women who were negative pap smear, negative HPV, out to about 5 years before we screen again. The other thing that's important to think about is HPV testing allows us to pick up when the disease first starts, whereas a pap smear, there's already some problems going on the cervix, so it moves that earlier on. So the next thing, though, that came up that people began to ask and question was, look at these two columns on the far right. There's not that much difference between HPV screening alone and a pap smear and an HPV test. And so for years, many people have begun to say maybe we should start just doing HPV screening. The thing that makes this also exciting for some people is this testing could be something that could be in your local Walmart, CVS, and the woman does a home HPV test and comes in when it's positive. Really, and the reason I say that's exciting is, remember, we're not seeing that much cervical cancer in women who are coming to the provider. We're seeing it in women who aren't showing up. So this may be a way to challenge that. So people began to look at this long term. And so these are women who were followed with pap smears over time. And you can see the top, and I apologize, I'm colorblind, so I call it a blue shade sometimes. The very top bar shows you if you just got a pap smear, how many women would progress to severe dysplasia over time. And you can see by 6 years out, it's 100 women per 10,000, even who were getting screened. Whereas if you look, the hashed bar in sort of the pinkish red color I'm going to go with is HPV testing alone, and then the bottom line is co-testing or doing both. And so again, is there really a difference between those bottom two lines or not? And that's the question that we're in the process of answering now. But some people have really already begun to argue we should flip the paradigm and do HPV screening as how we screen for cervical cancer. And I really think this will be what is done probably within the next 5 years to 10 years at most, is either you will come to your physician and they will, or nurse practitioner, and they will collect an HPV test, or I can see in some situations you went to CVS, got an HPV test, and here's the result. And then we will triage based on that result. There are upwards of 50 strains or types of HPV. Certainly we know the two most worrisome are types 16 and 18. They account for 70% roughly of cervical cancer. And so anybody that has those, we wouldn't bother doing a pap smear. We would move right on to doing a more invasive test, which is colposcopy. If you turned out to be one of the other groups of high-risk people, then we would actually flip what we do now. What we do now is we do a pap smear, and if it's abnormal, we do an HPV test. We would turn that around and do the pap smear only if the HPV was positive for this intermediate group. And then if you did not have active HPV, if you were negative, we'll say see you again in 3 to 5 years. There are some reasons that people are concerned about this. Number one, I don't know if you remember a few slides back in the Athena trial, there were a few patients, the sensitivity of HPV testing wasn't quite as high as it's been, so there's a little concern there. But one other factor driving this is the number of cyto technicians that are graduating is variable around the country, whereas you can run an HPV screening anywhere. So it's easier to do this algorithm. So I think you'll see this over the coming years be playing out. The reason this is so profound is study after study after study have shown us that persistence of HPV is the risk factor for cervical cancer. Again, not just getting it, but getting it and being persistent. And you can see women who have HPV 16 positive, that they don't clear it, the 10-year risk of getting cervical cancer is 17%. Type 18, 14%, and then you see it drops off. I wish we had called them intermediate, but they right now still call them other high-risk HPV types. And then you can see if someone is HPV negative, it is very, very rare for them to develop cervical cancer. In many low-resource areas, such as certain areas of South America and certain areas of sub-Saharan Africa, they are doing, if you see any provider, a single HPV test, and if you're negative, you're good. And they'll see you back, 10 years from now to make sure that you haven't converted. If you're positive, then they're trying to recruit you into screening. And that way they're only watching people that are of the highest risk to try to help. So just to sort of go back and look, if we just did a pap smear, again, the sensitivity, the chance of picking up the disease is actually pretty small. But the specificity, and this is what we have not talked about, and now I'm going to spend a few minutes talking about. The specificity is how often you are right. So if a pap smear says there's something there, there may not be something there, or they may have missed there's something there, but if it calls it, it probably is real. Whereas HPV test, you can see it's not going to miss it, and then the chances that it's wrong are about 10%. Okay? And the reason that makes a difference is this slide. Is one of the things that I do almost daily to women is a procedure called colposcopy. It's not a pleasant procedure for the woman to go through because we're doing biopsies of the cervix, and we haven't found a great anesthetic method for them, in the sense that most ladies complain more about the lidocaine we put in than they do about just doing the biopsy. But still, it's invasive, it's painful for the woman. So you want to make sure that you're only bringing people to colposcopy that really need to have that test done. Otherwise, you're causing undue harm. And so we wind up with this trade-off between making the test more and more sensitive, but the more sensitive we get, usually the less specific it gets. And so that's why we're juggling. So if you look, this is just from a paper where if you just, if you just did pap smears alone, that's the top line. In this study, they did 45,000 pap smears, and that caused them to do 10.8 on the far right colposcopies for every case of not cancer, but severe dysplasia, because that's what we want to catch. We want to catch them before they have cancer. Whereas if you did HPV alone, again, it's more sensitive but less specific. Now you're bringing almost 13 women in to find that one case of severe dysplasia. And I talk to ladies every day, and they argue, well, some would say, oh, I don't want to miss it, so I'm willing to be one of 13 and go through this procedure. And others are like, no, I've had that before. It hurts. I get this better. And that's an argument we're having. It's the same argument that's going on about mammography in the 40s, is the sensitivity. We're bringing tons of women back for additional imaging to find a small number of cancers. And is the fear, the worry, the coming back for more testing, the lost work worth that? And that's the argument we're having. The U.S. Preventive Services Task Force, which is our government's recommendation group, usually they're looking at what's the most cost-effective method for the population. A couple years put out these guidelines. They said that for women 21 to 29, they would just do a pap smear alone for every 3 years. And that's what most of us are following. Now, you say, wait a minute, that's when HPV was the highest. Remember that slide I said, remember this, that age group is when it was the highest. And the reality is, I don't want to know about all those first exposures to HPV, because 90% of them are going to clear that. And we're going to cause a lot of harm doing colposcopy and other testing in that group of women. I want to catch that group of women that can't get rid of it. So that's the reason this group tries to avoid using HPV. Now, I will tell you that there are some people now pushing to even slice this further and say, oh, let's start adding in HPV at 25. But currently, this is the recommendation. And then the recommendation for women 30 to 65 is to just use either cytology alone every 3 years or HPV testing alone every 5 years. Now you're like, wait a minute, where's the co-testing? Because most of our offices, at least among OBGYNs, are doing co-testing. And that's because, and I want to show you in a minute, the American College of OBGYN, the American Academy of Family Medicine have stuck to previous recommendations. But you can see already there are groups beginning to say one or the other, but don't do both. So I think we'll see that evolution. So the last thing I want to spend some time on is to go over our current guidelines that are what most people are recommending, and make sure you understand why we're doing what we're doing. And it is, anytime you're screening, you're trying to balance the benefits and the harms. I love Google Images, and I was like a demographic group of adolescents, and this is the picture that came up. So, but let's first talk about women less than 21. And there's a lot of controversy about why we don't screen them, because many of them start having sex long before they're 21 and are exposed to HPV. Well, what should we do to prevent cervical cancer in this group? Definitely we need to be teaching safer sexual practices. We need to be, I'm a huge advocate for the HPV vaccine. It's now available for boys and girls. It's actually now available for men and women all the way up to age 45. We should, one thing that we're encouraging as OBGYN is to encourage women to come see us somewhere around their 15th birthday. So for the moms out there, we're not going to do an exam, but it's more to have the talk about what's normal with a menstrual cycle, what's normal about her, and then for those teens that are ready for that discussion, to make sure they understand about the concerns about unprotected sex and then contraception. But why don't we screen them? Shouldn't we screen everyone and make sure they don't get cancer? Well, this population is only 1 to 2 cases per million. So we would be screening millions of girls to find only a handful. And even when we've screened in this population, we never saw that we reduced that rate of 1 to 2 cancers. And you guys from my talk can probably guess why. Because those 1 to 2 cancers are girls that are not coming in to be seen. But in this, remember we talked about HPV is cleared better in younger women. This is a population that are able to get rid of HPV. So right now, we're not screening till age 21. Except, there's always got to be an exception, and that's women with HIV or any other immunocompromised situation. Screen them when you see them. So moving on to this 21 to 29 group, again, the Google image demographic picture of choice. Right now, again, we want to use cervical cytology, and that's the name we're trying to get to other than pap smear, but I don't think we'll ever get rid of the term pap smear. Should be performed every 3 years, and co-testing should not be performed, again, because it's a high prevalence time for the condition. There's a low incidence, and most of these are going to be transient infections that are gone and not lead to them developing a cancer or pre-cancer. So why 3 years? Well, here you can see you're really not going to affect that many women having cancer between that 2nd and 3rd year. And if you screen at 2 years, you're going to cause harm. So you're going to do, what is this, 30 or 40 more colposcopies to find 1 or 2 more cancers. So that's the reason the 3 year. And you know, I'm like, if somebody shows up at 2 years and 9 months in my office, I'm going to do the screening. It's not hard and fast. This is actually from an ad, so I can't say this is the demographically pleasing, but 30 to 65-year-old, which is where most of our work with cancer screening usually occurs. In this population, the preferred treatment, according to the American College of OBGYN, the American Society for Cervical Pathology, and the AFP, is co-testing. Now remember, the U.S. Preventive Services Task Force has already gone out on a limb and said we think we should change, but right now, if you come see me, you're going to get co-testing with a pap smear and an HPV test. But it's still acceptable if you are in a low resource area or you don't have access to it, just to do the cytology alone. Why can we go to 5 years between screening in women that were doing HPV testing? Well, you can see the bottom slide there. Your 5-year risk, even with just a negative pap smear, is still pretty low. It's 0.26%. But your 5-year risk if you got co-tested is much lower at 0.08. So that's why we're really comfortable spreading this out a little bit more. I have this conversation every day. We did such a job from a public health standpoint of saying, come in, get your pap smear every year, that now saying, whoa, 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 you don't have to, has been a challenge to help people. And then what about that population over the age of 65? This actually is an area that is extremely controversial right now with a lot of debate going on, but I'm going to give you the current guidelines and tell you what they are. The current guidelines are if a woman is over 65, her screening should be discontinued if 2 things are true. Number 1, she's been well screened for the last 10 years, and you know that she's HPV negative and had normal pap smears. And that's because, remember, HPV is a disease that from first exposure to developing cervical cancer in a woman that's not immunocompromised is a 25 to 30 year experience. So I've had a patient basically say, you're telling me if I get exposed at age 67 and I develop cervical cancer, that means I'm 95 when it affects me. And I'm like, yes, ma'am. It's a hard discussion to have, but that's the one you're having. The problem we have is, since our patients move around a lot, it's hard to really document that they've been negative for the last 10 years. Now, I always try to tell people this is a reward. You are HPV negative, pap smear negative, never had a problem with this, we can stop beating you up. It's still a hard conversation to have. But if they've had a history of moderate to severe dysplasia in the past, or if you can't document that time frame that they've been negative, or they were positive in that. I had a 63-year-old who turned up positive, and she's like, are you kidding me? I was looking forward to quitting this. They're stuck being screened for another 20 years or so. Now, the challenge here is, as the population of women over 65 grows, with the baby boomers aging into this population, the amount of new cases of cervical cancer in that population is growing. And so a lot of people are concerned that A, you're having more women, B, they're living longer. Are we going to miss more people? Back when the average age of death was in the late 70s, are we going to miss more when it's pushing up into the 80s? Right now it's still controversial because, again, the majority of cases in this population are women who just, oh, I stopped having cycles, I'm beyond menopausal symptoms, I don't go see a gynecologist. And their internist or family medicine doctor are dealing with their diabetes, their high blood pressure, cervical cancer screening, is not a big issue. Again, also, it's a late occurring disease. So again, the odds if you're HPV negative by the time you hit 65 of you developing cervical cancer are still pretty small. And the final thing is, if you use just pap smears, unfortunately for ladies after menopause, the estrogen level drops, so the vagina becomes much thinner, much more what we call atrophic, and so it leads to false positive findings on your pap smear. So the test is a little worse as well. So again, this age, the reason it's controversial is this age is really balancing benefits and harms. Now, what about if you've had a hysterectomy? I always put this in here. If a woman has had moderate to severe dysplasia and she has a hysterectomy, she still needs to be screened. But if a woman was HPV negative, has never had anything higher than that severe dysplasia, you need to stop. There's no cervix, there are no cervical cells, you don't need to follow them. Because what you're going to do is make a nightmare for yourself by identifying false positive things that you chase forever. So again, it requires sitting down. Why did you have your hysterectomy? A lot of women, most women over the last 20 years have an understanding. I always tell the story, my mother, when I ask her why she had a hysterectomy, she's like, they told me it was time, so I went and did it. I'm like, I can't believe you did that, but anyway. But if they had their hysterectomy either for a pre-malignant condition or they had a history of a pre-malignant condition prior to the hysterectomy, then yes, they need to be screened because there's still a potential. But if they had it for fibroids or bleeding and have always had normal testing, you can stop and you don't have to follow them. Now, I think I'm going to move slowly through just a couple things of how this plays out. And your slide deck has a bunch of slides. Don't panic. I'm not going to go through all of these. But I want to show you what you would see if you played through on the app. I'm going to, and actually I should stop for a second and say, a lot of times we worry about, is it an adequate pap smear? And it's not only you need to see cells from the outside of the cervix, what are called squamous cells. I always joke, those are like tile floor. They're hard, they're tough, they're able to be exposed to the world. But you need to see those cells up inside the cervix. And those are what are called endocervical cells. They're more easy to be affected. And so the question was, if I don't get an endocervical cell, do I need to bring the patient back in and redo because I didn't get a good specimen? And that's still a question we ask. When you go to the ASCCP website or you buy the app actually brings up the answer, but any patient can go on this website and actually pull this up and look at it. So a lot of times when I have patients that are concerned about our management, I will pull up in the office and say, here's my playbook, here's what we're doing. If they're less than 30, you don't have to worry about if you don't find endocervical cells. If they're HPV negative, if they're over 30, you don't have to worry about it. And then if they're positive for HPV, so again, the presence or absence of endocervical cells doesn't really matter as much anymore. It's really that HPV status. But let's say, so this is how this all plays out. And again, I'll be glad to show some of you that are here if you don't have the app to walk through the app. It's a lot easier than looking at these flow charts. But let's say you're a woman that comes in, you're 34, I do a screening on you, and your cervical cytology is negative, but I tell you a few days later that your HPV test is positive. Well, you can see that there are two acceptable approaches. One is to bring you back in 1 year, or the other is to do HPV DNA typing. Now, the good news is most of our labs now will give us that HPV DNA typing right up front. I have seen referrals from some hospitals that don't, but most of them are now. But if you repeat it again and everything's negative, you can put them back into the screening bucket. I was trying to see if I have a pointer to show you, but anyway. But if they're positive again, then we move them toward colposcopy. If they're HPDNA, remember we talked about was these two high-risk types, 16 and 18, we're going right to colposcopy. If it's anything else, we can repeat in 1 year. So these are kind of just to give you an idea of, we have so much information that we can take every little pap smear now and play it out. And I will tell you, do I remember all of these by heart? No, I don't. And that's the reason buying the app, if you do this for a living, is something I highly recommend again. Here's just where the data for that comes, and this again makes the force. The good thing about the Kaiser system in Northern California is it's all integrated, so it's a pretty diverse population, and we get a lot of data on a lot of pap smears. But if you have negative co-testing, so you were negative for both, again, I showed you this earlier, your 5-year chance of developing this almost precancerous lesion is 0.08%. And then, but if you look, if your pap smear is abnormal with what's called atypical, but your HPV test is negative, again, still the rates of precancer or cancer are pretty low. But look what happens when it flips and the HPV becomes positive. Suddenly the rate of at least developing a precancer goes way up, and then the rate of developing a 5-year. So again, HPV has really changed. Are you positive? Can you clear it, or can you not? And I'm going to spend, and probably close with this, because otherwise you'll throw me out for being bored to tears as I run through all these. But for all of you, this is probably the most common abnormal pap smear that you will see. And that is that this atypical squamous cells of undetermined significance. what the cytotechnologist is telling us when they see this is the pap smear doesn't meet criteria for a pre-malignant or a malignant category. It just doesn't look normal. And they're saying, and I always laugh, they're saying, don't ask us, we don't know what this is, look at it a little more. And so what we by definition have done, most people have moved to, on the left of the slide, the right as you look at it, to doing what's called reflex HPV testing. In other words, they don't even call us. The minute they see they're going to call it atypical, they run an HPV test. If you don't have access to an HPV test, bringing somebody back in a year is acceptable. And if the HPV test is positive, then we bring them in for colposcopy. If the HPV test is negative, we say, see you in 3 years. Because again, remember the slide before, even if, did I go the wrong way? Yeah. Even if the atypical is there and if they're HPV negative, the chances of them developing anything are very small. Now, this is a difficult conversation to have in the office. You want to reassure this woman in front of you that everything seems great, that she's going to be fine. But by the same token, she's somebody you want to see at that 3 to 5 year mark, whichever you want. You do not want to miss her. Because there's nothing more that scares me than a patient that I said, yeah, I had an abnormal pap smear 5 or 10 years ago, but I didn't go get anything done. That's who I'm really, really worried about. And again, this is just to show you those rates that we talked about before. We could go on, but I'm not going to bore you with this. The one thing I would try to encourage people is nowhere in our current guidelines recommend, except for never say never, never say always. In all but one very rare result, nowhere asks you to bring people back in 6 months. And I still see people who are brought back 6 months, 12 months, over and over and over. And the good news for women about HPV is it's not, unless you're immunocompromised, it's not a rapidly progressing disease. It is very slow. And so we want to give time for your immune system to work. So you want to make sure you do your surveillance, but you also want to make sure that you don't intervene too quickly for these mildly abnormal things. I always tell people you want to be right there on the sidelines to catch that 1 or 2 people who move on to that severe dysplasia right there. But you don't want to beat up the 100 that just have a mildly abnormal smear, and I hope that makes sense. I was going to look through to see if there's anything. Oh, there is one other pap smear that, since I have a few minutes and I get in trouble if I stop too early, so I do want to make sure you realize that is wholly different. And that is if you see the result, atypical glandular cells. That is a much more abnormal pap smear that you need to pay attention to. That's saying to you the cells, not the ones that commonly cause cervical cancer, those squamous cells, but the ones within the canal of the cervix or further up have something going on. This is a place where we found that HPV is extremely valuable, as I talked about before, but these people need not only the colposcopy, they need an endocervical specimen and a biopsy of the lining of the uterus. So if you see this, it is a much bigger deal than the atypical squamous cells and needs a much more extensive evaluation. I always tell patients that do this that they were gambling and got snake eyes, because these are 3 of the worst, not worst, but the meanest procedures I can do in the office, or most uncomfortable, I shouldn't say meanest, but to evaluate this. So if you see that, please treat it as a little something different. And there I'll stop. I've included the references I used for this, most of them I have to give credit to Dr. Warner Huh, who many of you may know. He's in our office in our GYN oncology division and has been instrumental in HPV testing all along. So with that, I'll stop and answer any questions that the group here in the room has, or I don't know if we can take questions from the field. I'm hearing no. So thank you.